These are all research-funded grants, and none of my disclosures include any paid presentations. Just want to talk a bit about the importance of staging and a few of these other things. So this is why I say that I think it's no one-size-fits-all. Some days you're calling the interventional radiologist, and some days you're calling the pulmonologist, and some days, quite frankly, you should call your thoracic surgeon directly. It really gets based on these sort of 4 presentations. One is this direct invasion of the mediastinum. You can see the pulmonary artery has wrapped around. This patient actually, if you can see all the cuts, has nothing but an endobronchial lesion. CT is negative, but a central adenocarcinoma that has N1 disease. This is the typical discrete N2 disease with a single 4R lymph node, and this is a patient who has a peripheral clinical stage 1 tumor. And so when I see a patient, I look at these 4 presentations and I say, well, you know, where would I go next? Would I go with Ebus to these cases? And when you ask that question, the first thing that you should answer with is, well, what is the false negative rate of PET and CT? And so here's the false positive rate, very rare, almost no false negative rate. Here what's interesting is PET and CT don't behave very well in patients who have central lesions. And you know, you ask yourself, well, why don't they behave well? Well, it turns out that with central tumors, you can have microscopic disease that's metastatic to the mediastinum. Same with the discrete large lymph node. You can get a false negative and a false positive rate with PET, and we all know that. If you see patients with a hot PET and a single lymph node and a patient with a post-obstructive tumor, it might just be an inflammatory lymph node. And then the last patient sort of begs the question, there's a low false negative rate, begs the question, do you need a Ebus or any kind of staging at all? Can you take this patient to surgery? What I would tell you is this is actually the smallest studied group of all. We really don't know what to do here, and sometimes we sort of flip the coin and say, well, today we'll take them for Ebus to pre-stage them, or we'll send them straight off for surgery. And it depends. Actually, it's sort of starting to depend, for me, on the size of the tumor, the T level. Again, there are multiple ways to stage the mediastinum, and you have to think about your local expertise here. If you can do mediastinoscopy really well and you don't have Ebus capabilities, then do a mediastinoscopy. I kind of don't care what you do as long as you do something to stage the mediastinum.